Well, I think Prof needs no, if at all, minimal introduction, Prof. You are our lead for the Endometriosis Center. Prof is a consultant gynecologist with special interest in minimal invasive surgery and also in reproductive medicine. Being the lead of our Endometriosis Center, I think, Prof, with you and the rest of our team, I think we've gone leaps and bounds to where we are. So thank you very much, and over to you.
Excellent. Thanks for the introduction, and thanks for keeping to the time. That's going very well so far. So just taking on from the previous presentations, I think now it is time to look at the role of laparoscopy. Where does it lie? Do we offer laparoscopy for everyone with symptoms? Do we offer laparoscopy, or do we offer MRI first? I think it's important to be dealing with a complex area. No one modality, no one treatment suffices for all. I think it's something that has to be tailored, has to be counseled, and has to be discussed with every patient. So let's, without taking too much time, let's look at 4 points. Firstly, a brief introduction. I think this might overlap with what has already been said, so I'll go over it very briefly. Then, when should we consider laparoscope, and how can we interpret what we see at laparoscope? And finally, a simplified chart that we follow in our unit as to what to do when we see patients suspected of having endometriosis. So as has already been said, it's a huge problem. The diagnosis is very challenging with all the modalities, not just the MRI, even with the laparoscopy. There's no gold standard as it stands. There's been this famous report, APPG report, 8 years of delay. And I can tell you, and I'm sure all those who work with endometriosis, that's the most frustrating thing for women with symptoms, debilitating symptoms, is lack of diagnosis. And the most difficult time for any patients to tell her that you have no endometriosis. You think this might be good news for some people, but in fact it may come as bad news for people because they don't get to the bottom of their symptoms. And this is the number of visits to the GP and to the even accident emergency. 58% of women visited GP more than 10 times before getting a referral, and visited doctors 43% over 5 times, and so on and so on. So we can see where the dilemma is, and this is not just in the UK, it's a worldwide global issue, there's a delay in diagnosis. So when should we offer laparoscopy? So we have patients coming with chronic pelvic pain. So chronic pelvic pain, we have to obviously remember that it's a pain that has been there for longer than 6 months and severe enough to disrupt the quality of life of patients. And that has to be assessed carefully before making or labeling this as a chronic pelvic pain. So when we have a situation with all the features that someone has already alluded to, of the classic presentations of symptoms that suspect that this patient might have endometriosis, then you go on and examine the patient, and you may or may not find any sort of pelvic and extrapelvic symptoms that may be suggestive, highly suggestive of endometriosis. Okay, and this is when we should suspect that this might be endometriosis. The pain, usually it can, now we know that it can happen as young as 14, 15, and as old as 55 or beyond. Even postmenopausal women can have endometriosis, but the peak age is late 20s, early 30s. This is the peak age of endometriosis. We know the classic pattern of pain, the Ds, dysmenorrhea, dyspareunia, dyschezia, dysuria, and all these symptoms, and they're worse around ovulation, worse around the period. And the pain is not responsive to simple killers. And there's a major feature of the pain. It is progressive in nature and quite debilitating in most women. So when we have these features, we can consider laparoscopy. we have to remember, as already been said, that there's no correlation between the symptoms and the pathology. And in fact, 20% of women with disease, which can be very severe, are completely asymptomatic. So, and they only discovered incidentally. Like many times we sent a patient who had laparoscopy for other reason, and they just found that she has endometriosis. Now, as we said earlier, even if the patient has all the classic symptoms and very severe pain, and we scope them, and we take biopsies for histology, and a third of them has nothing, unexplained. And this tends to be one of the worst types of pains because there's no pathology to cure or to get rid of. And a third will have endometriosis, and the rest you can see. So, when should we do the laparoscope? We have to remember that it's no longer the gold standard, used to be. And because now we have modalities like the MRI and the scan that can tell us a great deal before resorting to the laparoscope and make the diagnosis. Okay? But when the clinical examination is negative and the imaging is negative, then at that point we still don't know whether there's endometriosis or not. And should we consider empirical treatment first, as the question that was said earlier, that should we consider empirical hormonal treatment? I think the answer is obviously depending on a number of factors, the findings on examination and the finding of the scan. It is recommended to start some empirical hormonal treatment and painkillers as appropriate. And if this doesn't work, then we could take to the next level. Now, should we consider is it better for the patient and for the long-term outcome of this patient to, if clinically it's all negative and imaging, to offer laparoscopy first and then treatment, or treatment first, try treatment first and offer laparoscopy? I think the answer to this, we have to remember that the laparoscope is very challenging to diagnose. But the answer to this particular question is that there is no evidence-based approach whether to do laparoscope first or to do the treatment first. Most women would have already had some form of contraceptive pills or other hormonal treatments before arriving to a gynecological clinic. So at that point, would you offer laparoscope first or do some treatment first? Let's see what the latest guidelines published last year say. So if negative imaging empirical treatment was unsuccessful, then you offer laparoscope. So that implies that you do the empirical treatment first. That doesn't answer the question. Now, always, as already been said, laparoscope on its own is not enough. We have to take biopsies. We have to take tissues from the common areas, which I will show in some images later. And until the histology is negative, we cannot be certain. Even a negative histology does not rule out endometriosis. And the reason being, we send some parts of tissues from the pelvic side walls, from pouch of Douglas, from the anterior compartment, peritoneal biopsies sent, and they make slides and look at a number of these blocks. And if they find some cells, they will say there is endometriosis, but they don't look at all the blocks. They just choose a number of them and look through them. So it might be missed histologically as well. So this is why neither of these is a gold standard. It can be considered laparoscope versus imaging. No evidence of superiority of either approach, and pros and cons should be discussed with patients. So it's counseling, it's discussion. Some patients are more keen on having a diagnosis. They say, I just need to know what's going on before and they feel that by giving empirical treatment, sometimes they say we are just masking so some explanation needs to go on here, that it's not just masking, it's suppressing if you give hormonal treatment. So again, there's no right or wrong here. It's a case of probably offer medical treatment first, and if this works, then we just monitor, and at some point, if the patient, the pain gets worse, or a patient wants to start a family and she has to stop the hormonal treatment, then laparoscopy could be offered. And again, even if we find endometriosis, as in this shown in this picture, or one of these pictures, is it actually the cause of the pain? We know that, so we do remove endometriosis sometimes, and the pain doesn't go anywhere. It's still there and as bad. And sometimes the pain goes away for a while and then comes back, and when you scope them again, there's nothing. So as said earlier, the laparoscope is not the magic cure. It's a diagnostic tool and also a therapeutic tool as well, but it's not 100% cure for the condition. So what do we expect to find? And what is the chance of finding endometriosis in someone with classic symptoms? As we said, 35% of these women have no visible pathology at least. And when we see it, we have to not just say there is endometriosis, we have to determine few things. One is the widespread of this disease in the different compartments of the pelvis, as Rathi has very well demonstrated: anterior, posterior, lateral, pelvic side walls, the adnexa, where and how extensively it is spread, and also the depth of the lesions. How deep is it? There are 3 levels of depth: superficial, which is just a peritoneum; deep, without invasion into organs, so that's one level of depth. And then the next level of depth is when it is infiltrating into the organs, like Rathi has well demonstrated, into the bowel, but we haven't seen over to the ureters. It can also infiltrate the ureters and the bladder and the nerves. So, and then also in addition to this, the 4th element, these are the 4 things we will need to be mapping and determining. The 4th thing is the amount of fibrosis and adhesions, and these are 2 different things. Although adhesions are a form of fibrosis, but there are deep fibrosis, which could be the only feature that we can see, as we will show in some of the pictures. So the extent of these adhesions, a completely frozen pelvis where all the organs are stuck together, the bowel is pulled up to the fundus, the ovaries are kissing ovaries, there's no anatomy in essence. So all these, and this is why we have seen, I'm not going to repeat the staging again, but we've seen different ways of staging the disease, and nothing is really very comprehensive in giving you all the answers to everything. And eventually, the extent of the disease, not just by looking down the scope, but sometimes you have to dig deeper into the tissue to see how extensive it is and how much infiltration it is into the different organs, the bladder or the bowel or the ureter. So if we see an image like this, I think most of us would agree this is likely to be normal pelvis. But is it really a normal pelvis? How often do we remove tissues from this peritoneum and it comes back showing some endometriosis, some glands and some stroma, confirming what we call the subtle or non-visible endometriosis? Now, obviously with this, there's no visible disease, and histology may confirm there's nothing, but again, that leaves some uncertainty, a small degree of uncertainty that it might have been missed with the laparoscope and even with the histology. And sometimes, and it's a very, very difficult. I've seen very many young women being frustrated when they tell them you have nothing. And I see many women getting very emotional, even crying when we told them they have endometriosis, and they say, finally, I found the cause. It's not all in my head. It's a very common scenario. So counseling is really crucial in these, and it plays a great part in our management. So when we see this, we start to see some features here, but none of the classic visible diseases. See some inflammation, some fibrosis. You can see some fibrosis here, but is this endometriosis? I think the only way to know is to take the peritoneum, which shows the fibrosis and the hyperemia, and then histology, in this case, definitely endometriosis, and sometimes it can be florid endometriosis, but this is quite superficial. You can't see any deep infiltrating or nodularity or fibrosis deeper. We didn't even have to dig deeper to the ureters, although we can see the ureter on this side. So this is the first example, the mildest form of endometriosis that you can see. Then as we get more, then you see something like this, and you think this is, yeah, it looks like superficial endometriosis, but we cannot really judge until we dig deeper to this one. And this very same patient, we have another image here showing that the ovary, just a little higher, is completely tethered. There's massive endometriosis, and it's all fibrosis, deep fibrosis under the ovary. And on the other side, the slide is not. On the other side, you see this on the ureter. Now, this is not just superficial. You can see the fibrosis. You can see the change in the tissue. This is quite a deep endometriosis. And I think this is a video that shows you only appreciate the extent of the disease and the depth of it when you start to dissect the tissue and you see the thickness here of the endometriosis. Okay, it's not just the superficial, and it is really stuck to the, you can see the ureter. There's a tendency of the ureter to be, the ureter is not infiltrated in this one, but it is affected by, it's tethered to the, so you have to remove the fibers attaching to the ureter. So this is just an example. Now we're getting deeper, although the visible lesion on the surface, you can only appreciate the depth when you start to open the space. Okay, so and this one again here is the same patient where we mobilize the ovary and remove the disease completely, and we have to do ureterolysis here. So again, the same scenario. This one is another, this is a healed, or someone has been treated by ablation in a previous laparoscopy. Now, if you do ablation on this, you're not actually treating. You're just removing some cells from the surface, but the actual pain comes from the deeper disease. A similar one here. This might be superficial, but again, you have to cut it to see whether it is deep or not. Now, looking at this is the classic that we all agree this very active endometriosis. But again, on the cervix, some of the uterosacral ligament, but there's a wider disease deeper to this. It's not just this black thing. And therefore, just doing lasering or diathermy to this, in my view, and I think most endometriosis specialists' view, is not enough. Again, there's another, you can see fibrosis here. You can see splashes of some activity that's going on there. You can see there's a lot of inflammation, but you can't see the visible classic implants. Again, this has to be, you have to do this, and histology confirms, and you have here you have removed the disease. There's a bit of in the pouch of Douglas as well. Okay, again, this one here, there's no visible disease as we implants and things, but there was this fibrosis on that side of the pelvis. And when you remove the fibrosis and do the ureterolysis, comes back definitely with endometriosis. Okay, and this patient, again, there's a lot of fibrosis here attaching and there's quite a significant amount of fibrosis here, and tethering, that ovary is completely tethered. You can't see the ovary in this one. This is severe endometriosis. Okay, and in this very patient, when you dig deeper, you find these adhesions. Again, this one here, this fibrosis there. There's a lot of increased vascularity in the peritoneum. Now you look at this one, you see there's definitely endometriosis here, and then you look on the other side. This patient has this massive fibrosis and adhesions. And in fact, when we do the dissection and cutting all these, we find that actually there was no endometriosis on that side. That was not endometriosis, believe it or not. But the other one is extensive endometriosis. Okay. Now this one here, this uterosacral ligament, this is bowel. This is a massive nodular disease, not infiltrating the bowel, but it's on the surface of the bowel. And you can only appreciate this once you start mobilizing the rectum and cutting a wide area to confirm the diagnosis. Now this one, we're going deeper and deeper, and on this one, you can't really see much in the way of deposits here, but this is what we call a grade 4 with a large nodule on the rectum that is hidden. Until you open the pararectal space and dig deeper, you won't really be able to identify this. Okay, now we come to an area where everyone would agree this is rectum pulled up, there's uterosacral disease. And here is the benefit from having a meeting with the MDT, including our radiologist, Dr. Rathi Kirk, who will tell you how deep the endometriosis infiltrating the rectum here, because You can't determine this with laparoscope. You have to dig, and you need to prepare. Do you need a bowel surgeon? Do you need certain kits? Do you need a sigmoidoscopy? And this is why the preoperative discussion with the radiologist and the colorectal surgeon is crucial to prepare for the day. If there's no infiltration, we can mobilize the rectum and shave the disease. Okay, now this is worst where it's completely frozen. There's no anatomy. This is bowel. You can't see ovaries. You can't see anything. But in fact, the adhesions can be mobilized. Not difficult. Is what you find deep. Is there a nodule? This patient didn't have a nodule on the rectum. It's just a messy fibrotic pelvis. And then when you do this, so I will conclude with our simplified flow chart. So when should we do laparoscope? Should we start with medical treatment first? Should we do this, and that? So it all starts with the clinical presentation and imaging. I think the basic imaging is, as Rathi said, is a scan. You need to listen to the patient. You need to examine. You need to do an ultrasound scan. And based on this, you either have a negative finding on both or either on both of them, in which case you have to do one of two things: either empirical hormonal treatment, this is the guidelines, but it needs to be discussed with the patient, or you can do the laparoscope. A discussion has to go on with the patient. If the patient wishes to have laparoscope, then we cannot deny her that, but we could advise that maybe because the scan is negative, the clinical is negative, laparoscope may be negative as well. So it's worth trying hormone, and if the hormonal treatment does not work, then we could always go to the laparoscope. Again, even after all this, we may still have uncertainty about the diagnosis. Histology is always required, as we said. So this is the first scenario where negative. You examine, you image, there's nothing. Okay? So you start with empirical, and if symptom relief, you can continue. And again, we will not be certain about the diagnosis. Obviously, this query can be very relevant to some patients. They say they need to know, and then you have to, as long as they have the information, I think we can offer them that. So the last, now, if you find something positive, there are two situations. And I think one is pathology that damages the ureter, or a large endometrioma, or damages the bowel. If you have some of these, then surgery has to be considered. Okay, so if you have this pathology, then we've got to consider the laparoscope and deal with it to save the kidney, or to save the bladder, or remove a huge endometrioma that needs to go. Now, on the other hand, if the pathology is not really requiring surgery, even if there's deep infiltrating endometriosis, even if the pelvis is full of endometriosis, surgery is not a mandatory thing, because we have to remember surgery is a high-risk surgery, and we will look at the risks in my next lecture. So it has to be justified, and it has to be offered to the patient. Even if the patient wishes to have it, she can have it, but after proper counseling. So if there's nothing there, hormonal treatment can still be option, but she can also have the surgery. Okay. So so this is the more exhausted algorithm that we follow in Derby. Okay. Starting from the GP, going to secondary care, to tertiary care, until we get to final stage of management. This is the ASHRI. It's much detailed, so I'll leave that for you to look at. So I conclude my my lecture, and I think I've kept to my time. Is that right?
Yes, you have, Prof. Thank you so much. Yes, you are actually a few seconds early.
Okay.
We're still on 10:44. No, I'm kidding. All is good. Thank you so much, Prof. That was really, really comprehensive, both surgically, medically, and highlighting the holistic approach that we need to take for the patient, really. Thank you so much. I've got a few questions, Prof, if you're happy to accept. It's Dr. Chowdhury who's asking, do we employ 3D or selective 3D or routine 3D to detect endo? I think I can answer that at the moment we're using 2D, isn't it, Prof?
You mean for the laparoscope?
Yes, for the laparoscopy, yes.
We use 2D.
Yeah.
I take it that 3D have some advantages,
Yeah.
and I think it's just getting, we are used to the 2D,
Yeah. Yeah.
but
I
we
think,
can
and
use.
yeah, I think, correct me if I'm wrong, Prof, but I think the value of 3D is much, much higher and better if you're doing robotic surgery. Because do you think
It's
that's,
it's 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 the same for both. It's the same for
is
both,
it?
but
Okay.
it's a
All
bit
right.
more complicated when it comes to laparoscopy because we have to
Yes.
wear glasses. We have to.
Yes.
It has some advantages, but
Yeah.
we have, on the other hand, we have the 4K. So the 4K gives you a much crisp and high
Yeah.
resolution image. So
Absolutely.
yeah.
Yeah. And then there's a Michelle Jones who's asked that should endometriomas be over 3 centimeters, should all endometriomas over 3 centimeters be removed, or can they be left if asymptomatic?
Um, Small endometriomas can be monitored for a while. But we have to be aware. That's a very good question because some of these can be fast growing. I've seen them growing over a few weeks to a massive size. Now, this is relevant because removing a small endometrioma is surgically not very challenging. It's easy. B, it doesn't cause much damage to the ovary. So
Ovary.
this has to be balanced with the fact that this endometrioma may not be needed to go and it may just stay the same for several months. So we have to take, as we said, the old, if the major symptoms
Yeah.
and the patient needs surgery, I think we need to remove it. But
Yeah.
if we can manage the symptoms, as a small endometrioma, especially for those going for fertility,
That's
then we could
absolutely.
monitor for 6 months
Yeah.
and then decide whether it is going. And again, if the patient wishes to remove it, based
Then,
on well informed, then we can remove it. Good
yeah.
question.
Oh, sorry, there's another question that has been asked again. It's, sorry, could the concurrent progesterone treatment like Mirena mask the laparoscopy findings for endometriosis? Prof, I think safely can say that no, definitely no. Please provide treatment because the changes will not regress. They will be kept at bay. They will not increase. But even if a patient is asking for a laparoscopy or is booked for a laparoscopy, she should be having some form of hormonal treatment. To the trained eye, whatever the patient is on, lesions will be picked up.
Yes, I think the real answer is we don't know. I mean, but we know it can keep it under control. It can remove inflammation, so that the inflammation is less. But the endometriosis tissue goes through a cycle. So it starts with active endo with bleeding and the
Yeah.
spots that we see, and then goes into fibrosis. The fibrosis is not going to go anywhere, and this can be extremely painful. So we shouldn't take it as something that will mask the disease, but it's
Yeah.
actually a treatment rather than
Yeah.
yeah.
Absolutely. Dr. Chaudhary, I'm so sorry. We're just short pressed for time at the minute. We've asked a brilliant question. You will get the answer to your question in the future, in oncoming presentations. And I hope you'll get your answers. Is negative laparoscopy with a high clinical suspicion, which particular areas would you recommend to biopsy? Prof,
Yeah,
if it
that's
is a
a
negative
good question.
laparoscopy with
Yeah,
high, yeah,
there are obviously four compartments,
yeah,
or actually, yeah, lateral, anterior, posterior,
anterior,
and
posterior.
axial. So we usually take the pelvic side walls are the commonest sites for
Yeah.
endometriosis, and then I look at the UV fold and I look at the pouch of Douglas. If they're completely normal, I wouldn't take any because obviously you're disturbing an area close to bladder, bowel, uh, some risks there.
Yeah.
But so I take these simply ureterize, take wide biopsies and send
Yeah.
them.
Yeah.
Then it can be cured if there's
Mm.
endo and also diagnosis.